Hi again, everybody. It's been a while, so I'll start with a case today that shows a bit of teaching points for both juniors and seniors. This is a chest CT of a 55-year-old male patient who had prior nephrectomy for renal cell carcinoma. You could tell that the CT is performed without intravenous contrast, seeing that the aorta and pulmonary arteries are not enhanced. The reason the CT was done is to make sure that the patient does not have intrathoracic metastases. Most of these cases could be performed without contrast. When it comes to checking for metastases, the big things you want to exclude would be pulmonary nodules, lymphadenopathy, bone lesions, and pleural effusions. Of course, many other things could be seen in case of metastases. However, most of what you're looking for can be really assessed without contrast. So one of the things you would be looking for would be lymph nodes that are enlarged in various groups. One of these locations would be mediastinal lymph nodes. Generally, a lymph node that's larger than 1 centimeter in its short axis is considered abnormal. One thing that you see in this case, to get out of our way, is this incidental high-density focus in the left hilum. As we mentioned, this is without contrast. This focus of density is equal to bone. This is a calcified lymph node. It's small in size. Small calcified lymph nodes within the mediastinum and hilum are common findings, especially in regions where TB is common. Such lymph nodes are non-concerning. They're just a pure manifestation of an old granulomatous exposure. Now let's go to the reason I'm showing you this case here. The main finding is this rounded structure. Let's start by the location of this abnormality. It's inside the mediastinum. It's immediately below the carina. Taking this step by step, this is the trachea. This is the bifurcation into the right bronchus and the left main bronchus. And as you see here, the abnormality is below that bifurcation, and this is why we call this a subcarinal mediastinal location. Now, this abnormality is subcarinal, well-defined, homogeneous, slightly lobulated, and has a short axis measurement of about 2 centimeters, which exceeds the normal short axis of 1 centimeter for lymph nodes. Now, if you consider this a lymph node, it would be an abnormal subcarinal lymph node, which could be metastatic. However, the important question here is this really an isolated metastatic lymph node? Because if this is not a lymph node, this changes everything. A mediastinal lymph node from renal cell carcinoma means poor prognosis. And if you want to give a patient such a bad prognosis, you need to make sure that your diagnosis is correct. One of the things that you would expect with a large lymph node is necrosis. You don't see that all the time, but it's something that you might see with larger lymph nodes. Very large metastatic lymph nodes are commonly necrotic, and they would have a heterogeneous appearance with a low density centrally. That's one of the things that you'd look for. However, not all large metastatic lymphadenopathy is heterogeneous. So what else could you do? Well, you have to make sure that you could assess the composition of this abnormality. Usually, lesions that have soft tissue density, such as lymphadenopathy, would have a higher density than this. To confirm the composition, you could measure the density in units that we call Hounsfield units. The denser the structure because of soft tissue components, the higher the Hounsfield units, while structures with fluid or fat would have Hounsfield units that are lower in number. For example, if you measure the Hounsfield units of bone, that would be in the thousands. If you measure the air in the lungs, that would be in minuses. The Hounsfield unit of water or fluid is usually less than 20, somewhere between 0 and 20. So if we measure this density here and it turns out to be somewhere between 0 and 20, you'd favor this being a fluid-containing abnormality. However, after measuring this, the Hounsfield units here were about 45 to 50. Now, such a higher density suggests a soft tissue component, but that's not conclusive for soft tissue, since there are pitfalls. Here's the CT after giving intravenous contrast. You could tell by seeing the enhanced and bright vessels. And we could see the subcarinal abnormality that is homogeneous, well-defined, slightly lobulated. By visually inspecting the lesion, you notice the same density seen as in the pre-contrast CT, without any associated enhancement in the wall, septations, or soft tissue components. If the lesion had clear soft tissue components, you'd see some degree of enhancement within the abnormality. Now, to confirm that there is no enhancement indeed, you'd have to compare the Hansfield units on the pre-contrast with that on the post-contrast. If there were no soft tissue components, the Hansfield units would remain the same, and that was the case here. The Hansfield units were still around 45. Putting everything together, we know that this is a subcarinal cystic component containing proteinaceous or hemorrhagic fluid. So what is the differential diagnosis for a subcarinal cystic abnormality? A purely cystic lesion that is common in this location is a foregut duplication cyst. A foregut duplication cyst is a congenital abnormality that arises from either the airways, enteric structures, or neural elements. Arising from the airways, this would be called a bronchogenic cyst from the esophagus, and esophageal duplication cyst from the neural elements, a neuroenteric cyst. The appearance of such cysts has overlap. The commonest in this location would be a bronchogenic cyst. The lesion has no perceptible or very thin wall that usually does not enhance, does not have soft tissue components, is typically of pure fluid density but could have some complex proteinaceous or hemorrhagic fluid densities. The wall of a bronchogenic cyst may calcify in a curvilinear appearance. The cyst may contain calcium that goes down to the dependent regions. Such calcium might give you a fluid calcium level, what we call a milk of calcium appearance. It's very important to emphasize that foregut duplication cysts, such as this bronchogenic cyst, should have no enhancing components. An enhancing component would mean a soft tissue composition, and that would change your differential diagnosis. Now, what else could you include in your differential diagnosis of a cystic subcarinal abnormality? One of the potential considerations would be a pericardial cyst or diverticulum. A pericardial cyst or diverticulum is related to the pericardium and more commonly seen in the cardiophrenic region, classically on the right. So a subcarinal location definitely favors a bronchogenic cyst rather than a pericardial cyst or diverticulum. Another differential would be that of a lymphangioma, which would look similar to a bronchogenic cyst with a few differences. First of all, bronchogenic cysts are way more common than lymphangiomas in the mediastinum. Second, lymphangiomas may show a more lobulated appearance or may insinuate in between structures. Third, and especially on an MRI, lymphangiomas may show septations. Fourth, lymphangiomas may show rounded calcific flibuli due to calcifications within venous components. Another differential diagnosis would be that of a mediastinal abscess. A mediastinal abscess could arise for many reasons, usually post-surgical or extending from an infection in the neck. However, in contrast to bronchogenic cysts where patients are asymptomatic, with abscesses the patient would be really symptomatic and sick. Add to that, an abscess would show you a thin or thick enhancing wall. It could be multiloculated or septated and would show inflammation around the lesion. Another cystic mediastinal abnormality in endemic areas would be an infection known as Hydatid cyst. There are many features of a Hydatid cyst, none of which are seen here, but the commonest would be a multiloculated appearance, or a large hydatid mother cyst with daughter cysts arranged along the periphery. Again, something that we don't see here. A very important question is, could this be a fluid-appearing necrotic soft tissue mass? Since a necrotic soft tissue abnormality could mean a necrotic lymph node from metastasis, lymphoma, or infection. And that's fortunately not the case here, since a necrotic lymph node would show you a thicker rim of enhancement or nodular peripheral appearance. By knowing these small bits and pieces of information, you change this patient's course from being unlucky to a lucky guy who has a benign bronchogenic cyst. Now let's summarize what we learned today. First of all, when you're looking for metastases in the chest, most cases could be performed without IV contrast. Second, the region at the bifurcation of the trachea is called carina, and a lesion in that location is called a subcarinal lesion. The subcarinal area is common for lymphadenopathy, but it's also common for other benign entities. Lesion describe the wall, describe the density, and describe the surrounding structures. Fifth, you could assess the density by visually looking at the color, by measuring the Hounsfield units, by comparing pre- and post-contrast CTs. Or for mediastinal abnormalities, you could use MRI, which is a very good tool that's underutilized in practice. We learned that simple fluid has Hounsfield units that are less than 20, but complex fluid containing proteinaceous or hemorrhagic components might have a higher number. The most important thing is to look at the post-contrast and make sure that there is no difference in the Hounsfield units pre- and post-IV contrast administration, and to make sure that you don't have any enhancing components to suggest a soft tissue composition. We also learned about the foregut duplication cysts, the congenital abnormalities, of which the commonest would be a bronchogenic cyst. Finally, if you're asking about the treatment, this is usually an asymptomatic incidental finding that needs nothing more than observation. In very rare occasions, the cyst might be symptomatic from superimposed infection or due to a large size compressing adjacent structures. In such cases, surgical removal or aspiration would be viable options to treat the patient. By that, we conclude this case on this luckier than what we thought patient. Thanks for watching, and see you with more cases later. Hello there, this is a CT of the abdomen with intravenous contrast administration on a 54-year-old female patient. This patient is known to have ovarian carcinoma, and the CT was performed to exclude metastatic deposits. The discussion today would concentrate on this lesion here, but before we do that, let's look at the normal side. So on the CT scan, this is anterior, this is posterior, this is right, and this is left for juniors to be oriented. And here you have the liver, the gallbladder, and part of the right kidney. The structure of interest is this here. And if you go from above below, you'll notice that this structure is above the right kidney, so this is the suprarenal gland or the adrenal gland. The adrenal gland commonly has this inverted V shape. This part here is the adrenal body. This part is the medial limb of the adrenal gland, and this is the lateral limb of the adrenal gland. So now that you know that, let's look at the abnormal side where you have an adrenal lesion. You'll notice that the adrenal body is okay, the lateral limb is okay, but the medial limb of the left adrenal gland is abnormal. So the medial limb of the left adrenal gland shows this large, well-defined, and homogeneous mass. The question is this metastasis or not, since we know the adrenal glands are common sites for metastatic deposits? This is a very important question, since we also know that adrenal glands are common locations for incidental adenomas. Adrenal adenomas are typically non-functional and discovered incidentally in an asymptomatic patient on imaging. They are benign lesions, and something that's very important to keep in mind is that even in a patient with primary cancer, adrenal adenomas are common. Now, most adenomas are smaller than this. They're typically homogeneous, which is the case here. However, the most important feature is that adenomas have a low density on CT. And if you measure the Hounsfield units on a CT scan without intravenous contrast, the density of adenoma should be less than 10. The reason the density of an adenoma is low is because adenomas contain intracellular or what we call microscopic fat. And such fat, which is intracellular, is different than the fat that you see here or you see here subcutaneously. If you look at the color of the subcutaneous or mesenteric fat, it looks different than what you expect with an adenoma. That's why we call this here, or the subcutaneous fat here, macroscopic or extracellular fat. Such macroscopic fat is seen in different lesions, for example, a lipoma or a liposarcoma. Now back to this lesion here. Measuring the Hounsfield units gives you a number of around 95. That's unfortunate because if you had a number of less than 10, you'd confirm that it's a benign adrenal adenoma and nothing else needs to be done. However, we have to remember that adrenal adenomas are classified into two types. The first type is called lipid-rich adenoma, where you have lots of fat, which would lower the density below 10 on a CT scan. The second type, which is still a benign adenoma, is a lipid-poor adenoma, where the fat is not sufficient to lower the density on CT. About 80% of the adrenal adenomas are lipid-rich, the rest are lipid-poor. So the fact that the density here is higher than expected does not conclude this as metastasis. Since the CT here is with intravenous contrast, this could be an enhancing lipid-rich adenoma, a lipid-poor adenoma, or a malignant lesion such as metastasis. And this is a case where you need further assessment by MRI, so let's go there. The most important sequence to differentiate between lipid-rich and lipid-poor adenoma on MRI is called chemical shift imaging. We'll talk about chemical shift imaging without going into much of physics detail. Simplifying chemical shift imaging, it's basically composed of two T1 sequences. For juniors, remember that T1 imaging shows you fluid as dark. This is fluid that's dark in the gallbladder and in the CSF. There are two important parameters to change the image from T1 to T2, which are the repetition time and echo time. Notice how the repetition time is about 190 and the echo time is about 4.7. With such TE and TR parameters, you're looking at what we call the first step of chemical shift imaging, or in-phase imaging. Now let me show you another component of the chemical shift imaging, which is still a T1, but we call this an out-of-phase sequence. Now this is still a T1, remember that. This is still a T1 sequence. However, it has this funny appearance in compared to the other T1 that we just saw, where there is this ink-like edging of the structures. This appearance is also called India ink or black boundary artifact, and it helps differentiate out of phase, which we're looking at, from the in-phase T1 sequence that we just saw a while ago. And if you look at the parameters of this out of phase T1 sequence, you'll notice that the TR is fixed, but the TE is decreased by half. So on this out of phase sequence, the TE is about 2.3 or 2.4. That's why chemical shift imaging is also called in and out of phase imaging. Now let's go back to the T1 in phase sequence and see how this is useful. Before we proceed, let's emphasize one important principle. We know that our organs contain water. Some organs may contain intracellular fat. And the way water molecules and fat molecules interact on MRI is different. On an in-phase T1 MRI, you cannot differentiate between intracellular fat and water. However, when you compare that structure to the out-of-phase imaging, things become different. On out-of-phase imaging, if the structure contains both water and fat, they oppose each other. So the signal from fat cancels that of water, and the structure would appear darker on out-of-phase compared to in-phase. However, if the structure does not contain fat, you only have water, and the signal would not change between in-phase and out-of-phase. Understanding such a concept, we'll see if this lesion drops signal when we look at the out-of-phase to denote the presence of microscopic fat. So this is the in-phase imaging. I'll switch to the out-of-phase imaging. Do that again. So you could see how the signal is on the in-phase imaging, and it drops significantly on the out-of-phase imaging. This contains intracellular fat. And that excludes metastasis and confirms this as an adrenal adenoma. So let's review what we learned today. We looked at the CT initially. We talked about the normal shape and anatomy of the adrenal gland. We learned that adrenal adenomas are very common even in patients with known primary cancer. Adrenal adenomas are typically small, well-defined, homogeneous, and most importantly have a density of less than 10 household units. However, 80% of adrenal adenomas are lipid-rich, while the rest of the 20% are lipid-poor, and for that you need an MRI. We talked about in and out of phase chemical shift T1 imaging. We understood if a lesion shows a drop of signal on out of phase compared to in phase, it contains microscopic fat. And if that's the case, it confirms a lipid-poor adrenal adenoma. Thanks for watching. Your comments are appreciated, and see you with more cases later.